The number of women who die giving birth in the U.S. each year has doubled in the last 2 decades, and 80% of these maternal deaths could have been prevented. Black women are also 3 times more likely to die from pregnancy-related complications than their white counterparts. These are just some of the shocking statistics on women's health care in the U.S. Dr. Denise Howard has devoted her career to women's health. She works tirelessly to help identify ways that health practitioners and hospital systems can deliver first-rate preventative care and interventions so that women's health problems are diagnosed early and so that women's health care emergencies are identified and treated so that no woman falls through the cracks. Dr. Howard is the site chief at York-Presbyterian Brooklyn Methodist Hospital, vice chair of the Department of Obstetrics and Gynecology at Weill Cornell, and an associate professor of clinical obstetrics and gynecology. A native of Columbia, Mississippi, Dr. Howard completed her undergraduate work at the University of Mississippi and then attended Johns Hopkins, receiving an MD in 1993. She completed a residency in obstetrics and gynecology at the University of Pittsburgh's Magee Women's Hospital in 1997, and then she followed with the fellowship in urogynecology at the University of Michigan. In this episode, Dr. Howard and I talk about disparities in health outcomes for women, from female cancer diagnoses to maternal mortality. And most importantly, we talk about the practices and procedures that can be implemented to address them. Dr. Howard is a real inspiration. I thoroughly enjoyed our conversation, and I learned so much from her. I know you will too. And with that, here's Dr. Howard. Dr. Howard, I'm so happy to see you. Thank you so much for coming and taking the time to join us on the interview today. It's a real pleasure.
Happy to be here.
I always think it's fascinating to hear about people's life experiences and backgrounds and kind of what brought them to their work. Tell me sort of what were your early influences or experiences that led you to this wonderful career in women's health?
I think it's a bit atypical. I grew up in rural Mississippi. I was the 4th daughter, 5 kids, ambitious and precocious, and probably got on the nerves of all my family members. But I was ambitious, and I loved to read. And so my family had this, I don't know if you remember Encyclopedia.
Yes. Oh, my gosh. By the way, where are they all today? I mean, some in the library graveyard. I mean, God help us. Right. I mean, we all had them.
So I read them. I was eager. And
amazing.
I was trying to decide what I wanted to do and read about medicine and, thinking that I was smart and ambitious. I said, okay, I'm going to be a doctor, and decided that I wanted to do OB-GYN.
And at what point did you know you wanted to specialize in women's health and being OB? Was it at that early age or later when you started?
I said it at that early age.
Wow.
I continued with that trajectory when I was in medical school, when I rotated through other specialties. I considered other specialties, but ended up doing OB-GYN again for a number of reasons. I think I was a student at Johns Hopkins and finished in 1993. Back then, the number of women in medical school had increased significantly. I had some really smart, ambitious classmates who I admired going into things like plastic surgery and cardiothoracic surgery and dermatology. Those were very competitive. And whether that was a message that was intended or not, I didn't think that my path to do something like that would have been easy. I thought OB-GYN seemed to be acceptable to everyone, meaning, something I wanted to do. All the folks around me thought that fitted with me, a woman, I guess.
Yeah.
A Black woman.
Yeah.
In either case, it worked out really well. I thought it would be an appealing specialty. I call it a happy specialty for the most part.
And then so you're in medical school, and then where did you do your residency? What was your first step after that?
So when I was at Hopkins, I did an MPH as well. They allow you to take a year between your medical school years, 3rd or 4th year or 4th year in graduation, to get a master's in public health, because at that point I decided I was going to stay in academic medicine. And doing a master's in public health provided a good amount of training to become a clinical researcher. So I took that extra year, and then I ended up going to Magee Women's Hospital. It's a part of University of Pittsburgh Medical Center in Pittsburgh. I saw it as one of the up-and-coming women's health programs in the country, and I was right in retrospect. They had made a lot of significant changes and investments. And it also was a great place to train. OBGYN is a really challenging specialty. It's a tough residency. And at the
because you're at the whim, right, of you can't control the schedule so much, right, because of
right.
Babies come when they come.
I think it's the perspective of how training should be done.
Okay.
And sometimes in that perspective, whether it's OBGYN, surgery, other really tough specialties, at that time, some places were described as more toxic than others.
Okay.
So I took that into consideration, and in choosing UPMC Magee, I feel like I made a really good choice, a wise choice. The people were really kind. They treated the residents well. It is a tough residency, but I think all of my colleagues and fellow residents really enjoyed the training, and it has a great reputation. They have some great, fantastic attendings and faculty.
It's interesting. I think most of us get our information or understand the experience of what it's like to be a resident from Grey's Anatomy. I mean, at least that's where the only place I draw.
Yeah, and they're spot on.
Yeah, my reference there. So you mentioned that you were focusing on the research piece. Did you have a focus on your research, or that you, with women's health at that time, or?
Having done the public health degree, preventative health was something that I focused on. I came across a quote from Ben Franklin. Has this quote where an ounce of prevention is worth a pound of cure.
Yes.
And he came up with that as it relates to fires in Philadelphia during his time. But that applies to medicine. I mean, if we invested a lot in prevention, that is so much cheaper than some of the cures that we're trying to do for a number of conditions. Plus, it's better from a patient perspective. I would much rather you help me prevent something than give me all of this attention and care trying to treat my cancer or whatever it is.
Right, after I've got it, yeah.
And so prevention was something that I decided I was going to work on. But more than anything, I just thought I wanted a career in academic medicine. I thought that, it provided enough of a variety, challenge, intellectual stimulation, and that's why I wanted to stay in academic medicine. And so then when I was at Magee, you have all these subspecialties: maternal fetal medicine, urogynecology, GYN oncology, and I decided to do a fellowship in urogynecology. Ended up going to the University of Michigan and being a fellow there under this fantastic guy named John Delancey, and started my research career. And the chair at the University of Michigan at the time had been a mentor when I was at Hopkins in medical school. His name is Tim Johnson, and it was a nice environment. However, I wasn't sure if I wanted to spend 100% of my time doing urogynecology and reconstructive pelvic surgery, because there were some other concerns that Black women have that tend to be outside of pelvic floor problems: abnormal uterine bleeding, fibroids. And when I thought I would eventually end up in the South, and when I thought about the population I wanted to take care of, I wanted to have a wide variety of skills so I could take care of a larger population of women. So I did urogynecology for a long time. I also took care of women with fibroids, and I did a lot of preventative care as well as obstetrics. And the beauty of that is that I think I got to know all of the challenges that happens with obstetric care, with preventative care, with specific problems around pelvic floor disorders, fibroids, pelvic pain, endometriosis, how we deliver that care, the surgical care, complications and adverse events around that. So in retrospect, it was good because it has helped me be a much better leader, because I understand all of those various subspecialties.
You talked about that you recognized that there were certain conditions that seemed to be more prevalent among Black women patients. Was that when you started seeing other maybe disparities in the level of either access to preventative care or, maybe conditions people were coming in with that you thought, gosh, I wish, if they had come in sooner, we could have addressed this particular thing?
Yeah, I think that at that time when I was practicing in Georgia, the thing that I noticed consistently is that not every woman understood her condition or even basic things that I thought it was important. I started to pay attention to health literacy and what that meant and how that impacted any person's care. It could be someone who's undereducated. There are also some people who are highly educated who have a limited understanding of what's going on from a gynecologic perspective or even an obstetric perspective. So I paid attention to that. And that being said, I sort of came up with a solution that I thought would work. But then I left the United States and we went to Abu Dhabi and we were in Doha.
This is you and your family, your husband.
Yeah, my husband and my kids. And it was in the consideration of coming back to the United States that I started to pay attention. And, taking a step back, I think, I don't want to say my head was in the sand, but it probably was. And you have this perspective that if you are delivering great care, then all of my colleagues in OBGYN and healthcare are all delivering great care. So you make the assumption that what you're giving and providing to your patients is being given and provided everywhere. And I quickly learned when I transitioned from academic medicine to private practice that wasn't the case. But, you're, as a young professional, you're focused on your skill set, becoming the best provider that you can be. For me personally, climbing out of all of the debt that I had accumulated over the course of my life, trying to become educated.
Yeah.
Raising a family, and then just becoming comfortable with my craft and my profession. So then when we moved to the Middle East, it was an opportunity to take a step back, get a lot of those things behind me.
Were you practicing medicine there?
I was practicing medicine there, yes. The intensity, very different, probably worth another conversation. But as I contemplated...
Was it more intense or less intense?
Less intense.
Less intense.
Yes. And as I contemplated coming back to the United States, I was there for almost 10 years. I started to pay attention to what was going on in the United States. And that is what was shocking to me. I read stories of women, both black and white, who had really dramatic outcomes. The ones that I keep in my mind are the ones who died around childbearing, and they shouldn't have died. And, those stories are dramatic. And I thought, what the heck is happening in healthcare? I mean, I've been gone 10 years. Things should be better for everyone. And then reading and paying attention and realizing that the maternal mortality rates are going up instead of down for all groups, but much worse for Black women, I started to pay attention.
You're in Abu Dhabi. Now when you say you're reading about this, is this in medical journals or you're just listening to the news, the regular media? And walk me through, and listeners who are listening, the landscape of what the health outcomes are statistics-wise for women in the United States versus women elsewhere. Because I don't know what the number is, but I've heard that for a first world, I'm using quotes, which you can't see because I'm we're not videotaping here, but countries, we are very high mortality rates for women compared to like countries, and our sort of healthcare access and outcomes are dramatically worse than they are in our peer country group, right? So what are some of those? Tell us more about that.
Sure.
That
I
landscape.
I'll start with life expectancy compared to what we spend. When you compare us to other developed countries like the United Kingdom and Germany and Sweden and Switzerland and even Japan, we spend twice as much, and yet our life expectancy is lower. A comparable country might spend about $6,000 per capita with a life expectancy of 82 years. We spend twice as much with a life expectancy of 76 years. So when we compare ourselves to other developed countries, we're spending a lot more and getting a lot less.
You mean a lot more in healthcare costs?
Yes, in healthcare costs. And I think it's because we're not just one country. In this country, there's really great care and there's really bad care.
Right. Interesting. Yeah.
And I think the folks who get the really bad care, and you combine the numbers, that's why it looks this bad. Because we know the U.S. has great health care. It's just not accessible to everyone.
So what about the numbers for women and women's health?
Yeah. So I mentioned that the mortality rates were climbing for all groups.
Yeah.
And it's something that,
Climbing, I'm sorry to interrupt you, climbing for all groups in the United States.
In the United States,
yeah.
Right. So when you look at the maternal mortality rates, and this is deaths within 42 days of the end of a pregnancy. And the rates for everyone, they measure it per live births. So back in 2018, it was about 17 deaths per 100,000 live births overall. It's climbed to almost 33 deaths per 100,000 deliveries in 2021. Then when you break those groups out to white, Hispanic, non-Hispanic, Black, in 2021, the mortality rate for white women was 26, almost 27 deaths per 100,000 live births. For Black women, it was almost 70 deaths per 100,000 live births.
So essentially 3 times.
Yes.
More than 3 times.
Yes.
You can see math is not my strength there.
No, but yes, about that. Right. And this is death within 42 days of a delivery.
Okay.
When you look at pregnancy-associated deaths within that 1 year, then there are even more deaths outside of that 42 days. So, What kind of things would happen that you would attribute? Would it be like a stroke from a clot, or what would happen outside those 42 days? So heart attack, stroke, mental health related deaths.
Okay. Oh, right, at postpartum.
Yes. Those are the things outside of the 42 days. So with you looking at these statistics, and you're over in Abu Dhabi and you're thinking, gosh, what's happened in the past 10 years? Mm-hmm. What do you think had happened over the course of that 10 years? Well, I didn't know, but what I felt I had a sense of responsibility. So I'm looking at the last half, or maybe last 1/3 of my career, thinking, what can I do? What should I do? And, being a Black woman, I grew up in rural Mississippi. This is my family. These are my people. And I'm feeling like I needed to be able to do something, but what could I do? What was within my power, and how am I able to contribute? Because everyone can contribute. And so I didn't know, but I just knew that when I returned to the United States, I needed to position myself in a role that I could be impactful. So that really struck me when you were speaking earlier about, earlier in your career, you're focused on developing your own skill set, particularly as a doctor, right? Because there's very little room for mistakes, right? So you're learning, you're being exposed to all these different specialties. You're, thinking about paying off student loans, all of that. Then you go over to Abu Dhabi, you get a different experience practicing medicine there. And then you're reading and hearing about what's happening in the U.S. and you're sort of compelled to go back and not just focus on your work, but how your work can expand to include trying to fix this problem and figure out why there are these disparities and how can you address them. Absolutely. Just being impactful. Because again, I feel very fortunate to have had the number of opportunities that came my way. And like Spider-Man says, with great, exactly, great responsibility. Yes, it's like Kennedy, the Kennedys, and Spider-Man had the same quote. Much as expected, right? Right, exactly. So anyway, feeling like I need to figure out how I can give back. But that is the thing; it adds value to me, right? It's the motivation for me. It's the reason I get up, because otherwise, plugging in, seeing patients without really thinking about the impact can get pretty boring. You come back, right, where you land first, and you have this newfound sort of goal or mission or thought in mind about what you want your next part of your career to focus on. Yeah, and, coming back to practice in the United States after being away for almost 10 years, it's very challenging. There's a lot of difficulties, and you have to prove that, you are able to practice because they haven't been able to keep track of what you're doing outside of the United States. So I had to look for particular opportunities. So I landed in rural Pennsylvania. Out by Pittsburgh or kind of in between? In between. Okay. I landed in Danville, Pennsylvania, a Geisinger Health System, which is a huge academic, great reputation for quality, and truly integrated health system. And what year is this, Denise? Sorry. 2019, right before the pandemic. Okay. Yeah. Oh, wow. Yes. And what better place to be in the middle of a pandemic than in rural America? Where you can go on walks. Right. It is. Yes. So I landed there, and that was a great transition back to the U.S. health system. And so one of the striking things that I saw, there were not that many Black folks there, though. So the population that I told myself that I wanted to serve wasn't there. And that's fine, more than fine, because, I'm still serving women, which is why I went into OBGYN in the first place. But one of the most impactful things that happened to me, it didn't happen to me, that I saw, was a patient who came in with advanced cervical cancer. She presented with bleeding. She had an advanced stage cervical cancer, and she had been in our health system. She had deliveries with us, and the question to me was, how can it be that there is a cancer that's completely preventable, someone who's inside our health system, and she didn't get the follow-up that she needed? And it was no one's fault. This is one of those examples of how systems can do better if, the right person is asking the right questions.
Right.
Because she was in our health system, and certainly communication had been attempted. But we failed, and we failed as a system, not because anyone did anything wrong, but just the processes we have set up are not effective. How to have convinced her that the problem that she had was serious enough that the intervention that we were recommended should happen. And how, if she interacts with our health system, and let's just say she's not an OBGYN, but she's in our health system, that someone else would have saw this important thing and say to her, hey, you had this happen a year or two ago, and you were supposed to have follow-up, and you really, really need to go get follow-up, because the follow-up and the treatment is going to prevent you from getting cervical cancer. And so I engaged the health system, and we started to have conversations, and we formed this great group of like-minded people, not just in OBGYN, but throughout the entire system, to do a better job with cervical cancer prevention.
And you mentioned the communication piece. So probably part of that conversation included, how are we getting in contact with our patients once they leave our system?
How do we track them? How do we ensure that if they're here, we do everything that we can to continue to communicate and to make sure that you're not lost to follow-up? Because, cervical cancer screening is, most people get cervical cancer screening.
Through a pap smear, right?
Yes, right.
Yeah.
Through a pap smear and human papillomavirus co-testing. The disparities happen when people get lost to follow-up. And when you look at cervical cancer screening abnormalities, almost 50% of people can get lost to follow-up.
I want to go back also to what you were talking about with these numbers, right? That over this period of time where you've seen the mortality rates of mothers go up in the U.S., what do you attribute that to? Is it the fact that the systems that you're talking about here at this hospital, aren't there to kind of monitor follow-up and follow through with patients? Is it the fact that with insurance companies, I know with doctors, they're only allocated, I think, a certain amount of time with each patient? I saw Robin Roberts at this lunch the other day talking. She was speaking. She was wonderful. And she said she felt this lump on her breast, or she was stretching or something and felt this lump, but she had just moved. I think she just got the job at Good Morning America, and her friend referred her to a doctor, and she just wanted to get a full physical. And as the doctor was leaving the room, she said, oh, by the way, I forgot I have this little lump. Do you want to take a look at it? And the doctor said, you should have led with that, right? Mm-hmm. So as part of it, just the fact that the doctors, I guess in that case, if that doctor had asked questions like, do you notice anything different about your body? Is it the time with the patient? What do you think it is about our country that we have the numbers that we have as compared to other developed countries?
Absolutely. And so, I didn't know, I knew that Robin Roberts had breast cancer. I didn't know any of the stories. The thing that strikes me is, did she get her mammograms when she was supposed to get her mammograms?
Right.
Because mammograms detect early changes that are breast cancer long before you can palpate.
Well, you know what she said? That doctor sent her for a mammogram. It didn't show up on the mammogram. It showed up on the sonogram.
Yes. Okay. Yes. The other impactful story that hit me when I was outside of the U.S. was Gwen Ifill. I don't know if you remember her. She was a Black journalist She actually moderated one of the Democratic presidential
Oh, yes,
election.
yes. I know exactly who you're talking
Yes.
about because she died, right?
Of endometrial
yes,
cancer.
Yes.
And, and in my whole career, had this thought that endometrial cancer is treatable. Endometrial cancer typically presents with abnormal uterine bleeding. If you evaluate and diagnose a person early enough, it's completely treatable. But in coming back to New York, one, I've learned a lot of things about uterine cancer and endometrial cancer disparities is, if there's a delay in diagnosis because you can't get in or you don't trust the health system, which is a challenge for a lot of Blacks in the United States, the trusting of the health system, we're all at risk of denial and delay in follow-up. But Black women are just at higher risk of dying from a similar diagnosis and stage of cancer, of uterine cancer, compared to their white counterparts. But Black women are also more likely to get a more aggressive form of uterine cancer, a different type of uterine cancer. And this is what I've learned from my colleagues in Brooklyn since I moved to New York. And so with her, I wondered, was it a lack of being diagnosed early, or did she have one of these more aggressive types of uterine cancers? So the contributors to the disparities, a lot of this. So you have under-resourced hospitals, limited access. One of the things that struck me when I started working in Brooklyn was how difficult it was to get a gynecology appointment. And apparently that's all across the city.
Or to get a mammogram, by the way.
Well, and that's like one of the priority things that we've been working on, and we've implemented some things to make it easier to get in for a GYN evaluation, especially if you have a problem. Bias in treatment. I mean, one, not being told, or, you come see me. There's certain things that you need at a certain age, right? There's certain screening tests, there's certain recommendations, there's certain things, if I do a good job and I take a nice family history, I might find that's a strange pattern of cancers in your family. You should consider genetic testing. We talk about it more. I may refer you to a genetic counselor, and you might get tested and find that you had a genetic mutation, which can allow us to provide some preventative therapy or treatment. That doesn't happen to every person who sits in front of their doctor for a number of reasons. I mean, first of all, we have to remember that doctors are human, but so with this specific example about family history and cancer screenings, the GYN oncology team at Weill Cornell looked at referrals. They have this hereditary breast and ovarian cancer center, and they looked at referrals to that center from 2013 to 2016. And they found that the number of referrals, they had 1,400 white women referred, 85 Hispanic women, 101 Black women, 113 Asian women. So there was a huge disparity in who was being even referred. And so this is innovative thinking and coming up with ways to remove subjectivity in care, I think, is one step that we need to take. So they developed a web-based cancer risk assessment tool. Takes the doctor out of it. And, they've been studying it, and they have utilized it in their clinics. At Cornell, they're actually even studying it now in our clinic. And this is an impactful way to allow this assessment to happen without being dependent on the doctor or the provider who's seeing the patient
to ask the questions?
Yes.
So the person takes that assessment. Maybe it's on like an iPad in the office or whatever it is. It goes into a system, and then what happens from there?
They can be referred for genetic testing.
Okay.
And counseling.
And, oh, I see. So the computer itself is making that determination based on their responses. It's not whether or not the doctor even thinks to ask.
Yes.
Okay, so I want to continue with what's happening or sort of what steps you've taken. You were in Pennsylvania, right? Then now you're in Brooklyn and heading up that hospital. And this is one of the things that Cornell is doing for their tracking. So what other steps are you taking, and how are you working to address that disparity? And the other thing you talked about, Black women or Black Americans historically having a distrust of hospitals or healthcare. I mean, one of the best ways to probably address that is to have more Black doctors, right? I mean, wouldn't that be something to help?
Everyone needs to feel like they are seen or reflected in their healthcare
Yeah.
providers. So as diverse as Brooklyn is, we are focusing on making sure that our providers are diverse. Not just Black, but, Asian, Hispanic.
And translators. I'm always so blown away by how York-Presbyterian, the whole network, has access to translators to help people who speak all different languages. I mean, you're in New York City and there's...
Absolutely. Yeah. So, yes, that helps. And all of it is multifactorial and complex because I have interactions with Black patients who don't necessarily trust what I'm telling them on particular things. And so there are a number of we're taking a multi-pronged approach.
Yeah.
So, yes, we're working on increasing the diversity of the healthcare providers. In terms of maternal morbidity and mortality, New York Times has been running a series of articles about maternal mortality and morbidity. And I think there was one headline that talked about mistreatment while in labor. And they talked about a good number of women and patients feeling like they have been mistreated in labor. And plus, delivering can be a scary endeavor. So one of the things that we have focused on is improving the safety in our labor and delivery and in our obstetric unit, but also improving the culture there so that people are focused on cultural sensitivity, focusing on making sure people have a great experience. You're at your most vulnerable when you're pregnant and laboring. You're at the mercy of the people around you. We have midwifery services. The midwives do a great job of providing that intimate care that sometimes physicians don't have the time to provide. So we have a huge midwifery group. But one of the other things that they did, and this was before I came, but they added doula services that started during the pandemic. So if women who came in who wanted that extra support, there are doulas available to be with them during labor. We also have postpartum doulas, and we have one outpatient doula, and we're working on expanding doula services. The other thing that we did was we added something called an OBG hospitalist group or program. And between the faculty person on call and the OBG hospitalist, we have 2 physicians who are in the OB unit all the time, and they focus on the safety. So they do regular huddles, regular rounding. They keep an eye on all the women who are laboring. They do practice drills because you know that if you have an emergency, you perform better if you've been practicing that emergency. So like a postpartum hemorrhage or a shoulder dystocia, or God forbid, if mom were to have a cardiac arrest. If we practice taking care of those emergencies, we perform much better.
When that emergency actually arises.
Exactly. And so those are the things that we practice on and we're focused on doing for the obstetric unit.
So you've got this system, right, for helping women, or the system identifying women that might need to go be referred for genetic counseling. You are having, like, within internal systems within the labor and delivery to make sure that people are being observed. It's a culturally sensitive environment. Being the mother of 3, as you sort of get set up, you come in, you're like, hair's on fire, like looking for a painkiller, at least in my case, wherever you can find it. And once that's sort of set up and you've had your epidural or whatever, then you're kind of on your own. And they come in and they, it's nice to have, not on your own, the doctor, but the doctors, they may be delivering a baby in another room.
They're covering a lot of things.
They're covering a lot of things. So knowing that there's 2 people that are just really tasked with just monitoring what's happening in each of these rooms is really terrific in terms of making sure that, you don't have a real emergency like the ones you just described. And if you do have one, as you said, you're practiced in what to do when it happens.
Yeah, and we have a team. And in addition to the faculty members that I mentioned, we have residents. And we have nurses. We have midwives who are there. There's 1 or 2 midwives there all the time. There's also private physicians who deliver there who are periodically there. And then, of course, nursing. And they work as a team. And so we help and support each other. And all of the training that I mentioned, everyone's involved with that. The nurses, the residents, the private physicians, if they are interested in being involved, the midwives, and the faculty.
This being such a passion and kind of personal mission of yours, what other kind of systems are you looking to implement or things are you looking to do or have been doing within your hospital that I know you would love to see kind of rolled out into the broader, because your hospital, Brooklyn Methodist, is now part of the New York-Presbyterian network, right? So, which is a huge network in New York. It's the largest hospital system and the most well-regarded. Being a part of that system is such an opportunity, right, for you to kind of test or roll out some of these practices that you've been developing in Brooklyn.
Yeah, I mean, you hit the nail on the head. It is an opportunity to trial some things and then an opportunity to expand that reach if it's effective. So I think there are a lot of opportunities. There are the immediate put out fire things that we're trying to do, like access for GYN. We've added advanced practitioner. We've added same day and urgent slots. I would like to expand and have specific programs around problems like abnormal uterine bleeding. To me, abnormal uterine bleeding is a first indicator that something's not right for a woman. And if a person has abnormal uterine bleeding, being able to get her in and evaluate it as early as possible is key to me. And, most of the times it's not cancer, but we would have an opportunity to detect cancer early and get women in for treatment. And that's an opportunity to prevent any long-term consequences from an early cancer. So we have plans to start an abnormal uterine bleeding program. The cervical cancer prevention that I mentioned to you is very important because cervical cancer should be in every event. We should not have any cases of cervical cancer. We have the tools. We have a human papillomavirus vaccine.
Yeah.
We have early...
Which you can get until you're 45, right?
Yes.
I think I just missed the window when that was rolled out,
Well, I think you can get it anytime you want if you can pay for it. The insurance will pay for it up to age 45.
I see.
Yeah. And so one of the things that, we typically do it in a preventative fashion, but all of the thought leaders on cervical cancer prevention and people who have HPV types that are high risk for cervical cancer and who have cervical dysplasia or precancerous changes, they are promoting the HPV vaccine for those type of women as well. The management of HPV-related diseases and cervical cancer is just one of them because you have vulvar cancer, you have anal cancer, you have oropharyngeal cancers. All of these are caused by human papillomavirus, and we know which types are the most dangerous types, and being able to identify people through screening, make sure that we provide the proper intervention. There's something called a colposcopy that we do on biopsies, and based on the biopsy results, do they need treatment? Do they need observation? Making sure that they are being followed if they need observation, making sure they get the treatment. But once you get treated, there's a follow-up period that has to happen, and that is years, because you could get recurrent dysplasia and you could develop cervical cancer even though you might have been treated. Very complex, but that's a program that we also have added, and we want to make sure that it is effective and impactful for all. So that means using technology and coming up with innovative ways to track and follow people, because this is impossible for one individual person or two people to do. And that's the same thing with a lot of the good quality care we have. Our challenge is implementation, because we're dependent on individuals, and individuals have biases, but they also are human. They need to eat.
Right.
They're hungry.
Yeah.
They're hypoglycemic.
And sometimes we drop the ball.
We drop the ball.
Yep.
We can't remember stuff.
Yep.
We forget stuff. You have a flight to catch. What if that 3:30 patient needs to have a more detailed evaluation, and she might have a sign or a symptom that might be a cancer, but you're trying to get to LaGuardia?
Yeah.
Right? So how do we introduce mechanisms to help provide information and care to patients that minimize subjectivity?
An example that you gave earlier is that this sort of this self-screening, right, with that, and having the computer say this person should be referred for genetic testing. But what other kind of technologies or other things have you started doing or would be on your wish list?
Yeah, so, I think with AI, machine learning, the deep learning, I think there's a lot of opportunities, and some of them have been started. So there is an opportunity to use this for tracking of cervical cancer abnormalities and making sure people are not lost to follow-up. It's been done successfully with something like pulmonary nodules and pancreatic masses. But how do we trial it with cervical cancer abnormalities or screening abnormalities? That's one thing that I've been exploring, and I want to explore more. The management of cervical cancer abnormalities is really complex. There is a national organization called the SCCP, long name. I can give it to you later if you want. But the thought leaders there, they have done a great job with figuring out a person's risk based on their PAP result and their HPV test results and their history. And it's gotten so complex that there's an app for it that you can type in this person's information and it'll tell you, based on this, she needs a colposcopy. Based on this, she needs this. Based on this, you probably should treat her.
What is a colposcopy?
The colposcopy is the next step.
Don't try to say that 10 times.
Colposcopy is the next step after you have an abnormal screening.
Okay.
If your PAP is abnormal or if you have one of those high-risk HPV types,
okay,
we have a way of putting a solution on the cervix and using a scope magnification to look at the cervix under magnification and take focused biopsies.
Okay.
The biopsies tell us what's really going on, and once we have a biopsy result, we know whether or not you need to have a treatment or whether the screening was abnormal, but you don't have precancerous changes, right? So this app tells us what our next steps are. But not everyone knows about the app. Not everyone will pay the $9 to get the app, and sometimes you don't have time to do that. So one other thing that a couple of universities have trialed in conjunction with the CDC is a way to incorporate that information into the electronic health record so that it's there for you if you're seeing a patient.
Oh, with the electronic health record is there for the doctor no matter where you're seeing it within the system.
Mm-hmm.
You mentioned the abnormal bleeding, and it just struck me that I was just with a friend the other day who was talking about that, but we're all in the age group of, going through the change, as they say. And that's a whole other piece we could probably talk a lot about, a lack of knowledge and understanding there until you kind of get there. And even then, there's more and more talk about it now and things available. But part of this, I would think, would be education and communication, educating women about these risk factors or things that they're seeing. And I don't know how, as a country, as a state, or as a hospital network, roll out, that information to the public. But I have watched enough of the shingles vaccine commercial to be properly terrified of getting shingles. And I'm like, can't wait to get my...
How effective is that?
Exactly. Right? I'm like, I need to get my shingles vaccine because of those commercials. So I don't know if this is where, there's public service. I don't know how we, getting back to sort of my earlier question about why is the U.S. where we are now? Is it that lack of information, that early intervention, to coin a phrase from Benjamin Franklin, but that we as a nation or as a state, or however we want to, we need to do more to kind of tell people what they should be looking for, how often they should be getting checked, really be more proactive in preventative care.
Right. And the challenge is that we have 50 states, right? And the states tend to sort of manage and control a lot of this. We can't mandate things that should be nationwide. So some countries have basically almost eliminated cervical cancer because they were able to implement a nationwide HPV vaccine. And you know how the COVID vaccine, and you probably heard about HPV vaccine and the challenges that were around that. So our lack of the ability to implement nationwide, not necessarily mandates, but just even a decision that you're going to do this education. Because I remember the Surgeon General.
The Surgeon General used to do a lot of commercials.
And smoking, right? How effective was that? I mean, yes, we need to do that around a lot of things. From a education perspective, we can do a better job of providing education to the patients that are at least within our system. And so we have some ideas to develop short video snippets because people don't like to read. They don't, you can't give people pamphlets anymore. Most folks won't read that. But around specific episodes of care. Let's just say you're coming in for, your doctor told you needed a specific procedure. How can we give you the information on that procedure where you understand what the procedure is and why the procedure needs to happen? Or during the course of your pregnancy, how can we deliver specific information about what might be happening in this week, gestational age, or this trimester? Because if you come in for your prenatal visit and they give you this whole bag of education material, epidural, birth plan, diabetes screening, all these other infectious screenings that we
What
need
to look for with preeclampsia, which I probably is one of the biggest issues I would think with maternal deaths, knowing nothing.
Yes, absolutely. How do you get all that information? Well, you're giving somebody a huge bag of pamphlets is not effective because most people don't have time to read it. So, we have my pregnancy app that's a part of like My Connect. And so
part of New York-Presbyterian network? Okay.
We want to develop little snippets of educational material that's delivered at the most appropriate time during the pregnancy. This is my dream, right? And so we've started to talk about how can we develop these snippets of educational material. We have it. We have information linked right now, but it's stuff to read, and there may be a few videos. But how can we make it even more seamless, and how can we make it even more appropriate? Because the knowledge is the thing.
Well, I was going to ask you, how is the hospital, now that Brooklyn Methodist is part of the New York Presbyterian network, is the hospital as a whole, I would hope, or I would assume, is being supportive of these efforts of you trying to be not only proactive, but creative about how you're getting the information out to patients? Because, it's only beneficial to have this thing be successful in Brooklyn so it could be rolled out more broadly.
Absolutely. And, they are. I mean, they developed the My Pregnancy app that was developed before I got here, right? Now it's, okay, we have a platform. How do we use it to make sure that patients get more specific information? And so, these things were thought about before I got here. I'm just sort of saying in Brooklyn, this is what we want to do as relates to this specific condition.
I wonder if you could one of the things we talked about disparities in care, and I remember Serena Williams was talking about her experience with her delivery and how she kept saying this, something is wrong. Mm-hmm. Something is wrong. And they were not being responsive. And she was very, very straightforward and persistent about that. And thank God she was. I shared with you my own story with my third child. Having my epidural, I knew that something was wrong. It was not working, and I was being told, I had a new OB who was delivering me because my old OB didn't deliver anymore. She said, "Oh, you're just nervous," and it's not. And I said, No. This has happened. I've done this before. I know this doesn't feel right. So part of it also is, if you feel something, say something, right? I don't know if the case of Serena Williams, if it was any kind of bias or disparity there, it could be also women versus men. I don't know. I just find sometimes, that even when we're describing how we're feeling, are not always getting the response that we need. And in some cases, that can have really serious consequences.
Yeah. And so when I give presentations often about, the things that we certainly can do, and I talk about we need to disrupt healthcare delivery. And I say specifically in OBGYN, but we need to disrupt healthcare delivery in all of medicine, because what we do isn't sustainable, and we're not able to deliver the best quality to everyone. We just don't have the resources to do it in the way that we're doing it. And you list names.
You mean our country doesn't have the resources?
Exactly. And our hospital systems, and we need to reinvent or reimagine how we do this. And figuring out how to remove some of the subjectivity is one of them. I have a list of names of people who have died because of that. They have similar stories to what Serena had. At least Serena was persistent enough that she finally got the CT scan and the heparin that she needed, because she knew she had a pulmonary embolus, because she had a pulmonary embolus before.
Right.
And being pregnant is the highest risk factor for having a pulmonary embolus. I don't know if you saw the Aftershock documentary.
No.
It's worth a look. It's an hour. It's really dramatic, but they focus on two women who lived in Brooklyn who died during the pandemic from pregnancy-related complication. One person had HELLP syndrome, and she went into something called DIC, where you're bleeding and you're not clotting. And then another person had a pulmonary embolus, and one of them had called the hospital and was talking about her symptoms, and they reassured her, and she ended up staying home way too long. Those are really heartfelt, just horrible outcomes that should not happen in obstetric. The other stories that I think about is there's one woman who was at a medical center in the Los Angeles area who had she had bleeding post an elective C-section. Her husband ended up presenting in front of Congress because of the just neglectful care, I guess. I hate to describe it as neglectful because I wasn't there, but she's bleeding after a C-section, and it takes more than 8 hours to take her back to the operating room, and she dies on the OR table from bleeding. There is a story that I read, and these two stories I know because the husbands had, articles written about them. But there's a woman named Lauren, her name was Lauren Bloomstein, who died somewhere in Jersey, and I think this might have been, the story came out, I think, in 2017, and then it happened a few years before that. She's a white woman who was a NICU nurse who handpicked her obstetrician, who decided to stay at her hospital because she would be cared for. She developed symptoms of severe preeclampsia that it took too long for them to identify. The husband called a friend outside of the hospital, and he called the name of the disorder out right then and there. And indeed, it was that. She had a stroke, and she died from a hemorrhagic stroke. And all of that should have been prevented. When we look at all of the maternal mortality cases that we talk about, almost 60% of them are preventable.
So when we look at the difference between our country's performance and numbers versus other developed countries, is the communication or the advocacy part of it? Maybe it's the disparities just in care, because you talked about, one hospital is not the same as another hospital, even though in these cases here you have some top hospitals, or in the case of Serena Williams, because it's Serena Williams, she's got a great doctor, presumably is in a great hospital, but these things shouldn't be happening in 2024 or whenever these things happen in the past 5 years. And in the United States, when we do have such access to great care and understanding, it's just a question of communication, advocacy, access.
And the quality processes in the hospital being effective, right? These things don't happen that often. And so you could be at a low-risk place doing deliveries for a number of years and have something come in that you don't notice because you haven't been taking care of these complex cases before, and you might miss those early flags that tell you this is not right.
So I think what you're saying is if there were some sort of a procedure, right, that everybody kind of follows, and maybe that's rolled out, within Brooklyn Methodist and then within New York-Presbyterian, and then, nationwide, it's Dr. Howard's way or Dr. Howard's procedure. But I'm serious about that, and just kind of like, this is what you need to, like when someone's having an allergic reaction, and you can see on these health forms, there's been enough people who have died from allergic reactions, right? What happens when you have an allergy? Is it a rash? Is there swelling? Are you having those symptoms? Kind of going through those things that might lead someone to notice, okay, maybe this person has preeclampsia. We need to screen for preeclampsia. We need to look for if it's excessive bleeding. All these things, if there were systems, people were checking and asking the questions, and maybe it goes into the computer.
Yeah, we need all sorts of innovative ways to address this. And all the things that we are doing in our labor and delivery unit, and that I know is being done in the labor and delivery units all across NYP, focuses on this. Obstetrics and having a child is not a safe thing. It's dangerous in general. But we have ways to take care of women to minimize those complications. Sometimes some things aren't preventable, but the majority of these major complications are. Not all of them, but the majority. And so, I'm confident that at NYP we have everything in place. The rest of the country, there are places where they're closing obstetric units. There are places where people have to drive miles and miles for a delivery. And then let's not even talk about the places where, because of the laws around abortion care, have impacted care for women who may not even be under the abortion umbrella. They're having a miscarriage, right?
Right, and they can't get access to care. I live in one of those places, being in Millbrook, New York, or a neighbor, Sharon Hospital, which is 18 minutes from my house. They're closing the delivery unit. I don't know if it's just because it's so expensive, it's hard to get, because I know the insurance is very high or it's just not a moneymaker within the hospital, and they have to decide what they're doing with their budget. But, if that's happening, and it was a big controversy in our area, that must be happening in other rural areas too.
It is. It's happening in a lot of southern states. And Some of it started to happen with hospitals closing in rural areas in southern states when some of them elected not to get the Medicaid expansion.
I see.
But, yes, you mentioned checklists, and I think that's an example of an innovation because with the surgical checklist that, I think that's a simple but very impactful innovation that happened to prevent wrong side, wrong person, wrong site surgery, right? Just a simple surgical checklist.
Well, I remember our daughter had a kidney condition. She had kidney surgery. And when they were bringing her in, they said, and it's her right side. And I'm like, it's her left. I mean, I'm like, you don't know which side it is? They're like, no, they kept asking us over and over which side. And it was actually because they were going through this checklist system. But for a moment there, I was like, you don't know what side they're no. He said, no, we're actually, this is part of, them being extremely thorough, of course, with their process, which is what you want.
Right. And that surgical checklist is probably in every OR across the world, right? And that's a simple but innovative, impactful solution. And those are the things that we need in just about every area of obstetrics and gynecology. We need people who are thinking that way, who are having creative thoughts and reimagining doing things in a very different way. I mean, access can be improved when you have a team-based approach to care. We need more advanced practitioners, but we also need people approaching care as a team. You have great doctors, but they can't be available all the time. And I think educating the women that we serve about how we're delivering care is a big part of that. Because it's not really helpful if a patient thinks that all of her health care goes through one doctor.
Right.
And so she calls, she has a problem, and she wants to talk to the doctor. And that doctor may not be available, he may be on vacation, but also how valuable is his or her time? Can a nurse intervene and address the concern that that person has and solve the problem without her having to have a conversation with the doctor or her having to wait for the doctor to read his messages and respond? So, women call with a number of concerns. An administrative person might be able to address the concern because it might be just, I need an appointment.
Right.
I need a refill. Or it might be, I have a problem that a nurse can answer. Or I have an issue that maybe an advanced practitioner can get me in tomorrow and take care of my urinary tract infection. And leaving the sort of more complex stuff for the doctor to attend. Because doctors are burnt out. They have gotten burnt out over time for a number of reasons, but most of it, I think, is based on us asking them to do way more than they should be doing.
Yeah, I've heard, too, that doctors are spending a lot of time dealing with insurance companies, and that's taking time away from them being able to see patients because of a lack of nursing staff or budget and admin that could otherwise or would otherwise maybe in some circumstances be doing that work.
Yes. So how can we make sure that everyone is working to the highest level of their license and providing a team-based approach so that our patients are cared for?
So if you could wave a magic wand, I know we covered a lot.
So I'll start with a big global thing.
Yeah.
Did you see the announcement from Einstein where I think her name is Ruth Gottsman, maybe I'm probably butchering her name, but she gave a $1 billion gift to Albert Einstein Medical School, making tuition free.
Oh, yes, I did see that.
Right. That is impact. And there are a few medical schools that have tuition free, but imagine the impact you would have if students didn't have to pay tuition.
There's more people going into medicine.
Well, or they're going into pediatrics.
Right, I know.
Or going into some of those specialties that people will choose not to go into because they have economic concerns and they want to be able to pay off their debt and live a prosperous life. Imagine underrepresented in medicine kids who just don't even have an opportunity. Imagine it's medical debt and educational debt that impacts choices and impacts who end up going into medicine. So if I could wave a wand, I would ask a bunch of multi-billionaires to endow medical schools all across the country, but also be very specific as to who you should allow into the medical school, right? Make sure that there's a diversity of students.
I love that because talking earlier about people being uncertain or nervous about health systems and the importance of seeing doctors that you can relate to or that look like you is a first step, I think, in some ways to getting more people seeking preventative care.
Yeah, absolutely. Resources and the time and support to develop some of the interventions that and the permission to develop some of the interventions that we've talked about. We talked about machine learning and AI, but, we have implementation scientists. You have human factors and health system design experts, change management experts. I think it's going to take sort of a creative approach to change how we do things. Unfortunately, a lot of people in healthcare systems, especially a healthcare system like ours, are aware that this is what is needed. We don't have the money, the resources to get some of this done, right? So that would be my magic wand.
Yeah.
If I could have a team and just sort of, this is my job, going through and reimagining how we can disrupt healthcare and
I think
make it
that's
better.
got to be doable.
Oh, I think so too. I mean, it's just
right?
time and
I think, well, it's just also kind of the argument of why it should be a priority, right? Because the hospital's resources are limited and they are directed towards certain departments. But having that kind of think tank or that group looking at how you can improve these systems
and the
only
permission
makes
the permission to try.
Right, exactly. Are you listening, leadership at
It's just because healthcare systems have the challenge of being sustainable. They have to keep their doors open,
yes.
Right? They have to keep their doors open, and then also, which is what I love about being where I am, is a commitment to taking care of underserved who may not be properly insured, or even we take care of a good number of people who don't have insurances. So, they have resource priorities, which I get and I understand. This is why we're talking about a magic wand, right?
Yep.
And I have sort of a side project that I have started to work on, and it's around the surgical consent process, that I have an idea of how can we provide people with proper counseling and the ability to understand what's been recommended. Because right now, the process is one-on-one. As a physician, I explain to my patient what's going to happen. A lot of surgeons may use some videos, but that's not consistent. A lot of people may use images and pictures, but that's not consistent. So anyway, money to develop that project.
Oh, I love it. Oh, I just think it's I love that you have, the way you described earlier, just sort of you now focusing your career still obviously on providing care, direct care to patients, but also looking about how you can improve systems more broadly so you can provide care to more people, more women, more effectively, to avoid some of these terrible stories and statistics that we talked about earlier.
Yeah, and I'm also trying to rub off on my colleagues.
Yeah.
So I have physicians that I'm trying to mentor and support and guide, certainly the people within my department, but students and residents, and hopefully I can infect them with this idea of disrupting healthcare delivery in obstetrics and gynecology.
Oh my gosh. If anyone can do it, I know you can do it. I know you can do it. Well, it's interesting. When you were talking about medical school and the importance of the team, it just occurred to me that perhaps that should be part of medical school training for doctors, is how they go about developing their team, the importance of the whole team, and then wherever they end up, they kind of relay that to the patient. So the patient knows they can call the nurse or the person who's doing admin, and everybody's on the same team and working towards getting them healthy or keeping them healthy.
Yes.
It was so nice to see you, Dr. Howard. I can't thank you enough for coming. I can't wait to see what happens next, because I know you're going to be waving a magic wand out there in Brooklyn, and real magic is going to be coming from there through the whole New York-Presbyterian system, but I bet even through all of New York State and hopefully beyond too.
Yeah, I hope so, and I'm happy to have this opportunity to discuss some of my ideas and vision, and hopefully there's some listeners out there who would be interested in engaging with us to help advance this mission.
Oh, 100%. I'm sure that there are. Well, I know I'm inspired too, so I know others will be as well. But thank you so much.
Thank you.
That brings us to the end of this episode of The Interview. A huge thank you again to Dr. Howard for joining, and thank you again for listening. If you enjoyed the show, please rate and review us on Apple Podcasts, and follow us on Instagram at The Interview with Leslie. A new podcast is released every Wednesday. Until then, this is Leslie, and don't forget to join The Interview.